I have no disclosures. So the question I would like to address and answer today is, can we use a single blood test to predict onset of AD symptoms? We know that Alzheimer's disease trials are difficult. AD onset is unpredictable and present in different heterogeneous ways, so that prevention trials must be long and large due to the unpredictability of the timing of symptom onset, making it difficult to identify people that are at risk for cognitive decline, who are exactly the people we would like to enroll in clinical trials. One solution to this problem is the DIAN approach of enrolling people from families with autosomal dominant Alzheimer's disease, where disease timelines are more predictable and better understood. So trees have a consistent growth pattern where they add one tree ring each year, so that, for example, if a tree has 82 tree rings, it's 82 years old. And we have learned that amyloid accumulates in a similar way, so that once amyloid starts accumulating, it adds a certain amount of amyloid per year, so that we can relate the amount of amyloid someone has to when they started accumulating amyloid. This idea is known as an amyloid clock, and it's been calculated several different ways. So we wanted to know, can we do the same thing with the blood test? And the answer is yes, and I'll show you today how we do that. And then once we develop our plasma clocks, the next question we had was, can we estimate using those clocks from when someone starts accumulating amyloid to when they start developing symptoms? So for our plasma clocks, we decided to use p-tau217 because in a previous study we found, in a previous head-to-head study, we found that p-tau217 was the superior predictor in distinguishing amyloid PET status, as well as tau PET status, cortical thickness, and cognitive impairment status. So what we have here are trajectories of different p-tau217 blood tests. We have C2N Diagnostics Precivity's AD2, percent p-tau217, the Fuji Rubio Lumipulse p-tau217 over A-beta42, ALZpath Quanterix p-tau217, and Janssen Lucent AD Quanterix p-tau217. And the gray corresponds to individuals where all of their plasma samples were below an amyloid threshold of centiliter 20, and red corresponds to people that have at least one positive plasma sample. And what we see is these trajectories appear chaotic, and it's pretty difficult to extract much meaningful information from them. So similarly, we have a collection of curves, and these curves are messy and tangled. But there are ways that we can detangle the curves and align them to make them more understandable and interpretable. So in a similar way, we can take these messy trajectories, and instead of plotting them as a function of age, as we were doing here, if we plot them as a function of time from when people are estimated to become plasma positive, what we see is that the trajectories line up. So for this study, we decided to use C2N Diagnostics percent p-tau217 for our plasma clocks, basically because it was available in two data sets, the NIGHT ADRC and ADNI. And we used two modeling approaches, clock modeling approaches. One is called TIRA, which integrates the inverse modeled rate of change that we obtain from linear mixed effects models to estimate time intervals. And we use SILA, which uses Euler's method for numerical integration with discrete rate sampling, which was developed by Toby Hauser et al. At Wisconsin. So what we see here is that if we look at the estimated age at which someone becomes percent p-tau217 positive, which we obtain from our plasma clocks, what we see is that that is a good predictor of when someone will develop, is a good predictor of time to cognitive impairment. And what we found was very interesting, which was that if someone became percent p-tau217 positive at a younger age, it took up to around 20 years for them to develop symptoms. versus if someone was older when they became percent p-tau217 positive, it took around 5 to 10 years. So there was a huge effect on time to cognitive impairment due to one's age at which they became percent p-tau217 positive. When we looked at individuals who developed Alzheimer's disease, what we found was that their age at symptom onset was well correlated with their estimated age at plasma percent p-tau217 positivity. And we found adjusted R-squared values ranging from 0.337 to 0.612 for our different models. And to put this into context, in autosomal dominant Alzheimer's disease, we see a similar level of correlation between familial age of onset with someone's actual age of symptom onset. So what we found is that we're able to predict, using someone's estimated age of percent p-tau217 obtained from our clocks, we're able to predict their age of symptom onset at a similar association as we are able to do in using familial age of onset in AD-AD. And furthermore, we were able to predict someone's age of symptom onset with a median absolute error of between 3 to 3.7 years, showing how well the models performed. So here we have a Kaplan-Meier curve on the left, and it's showing us that if we look at an estimated time from percent p-tau217 positivity to when somebody becomes biomarker confirmed with cognitive symptoms, we see that there's a really broad decline post-positivity of about 10 to 15 years where someone remains cognitively unimpaired. But what we saw was that this broad decline is largely influenced by someone's age at when they become percent p-tau217 positive. And so when we binned individuals based on their age at becoming plasma positive, we saw that people that were older than 80 had a steep decline after their plasma positivity time compared to those who were younger than 70, who took up to several decades to decline. So we made a web-based app to make these models more accessible. The web-based app allows you to input someone's plasma levels and their age, and then it outputs where they would be on the plasma clock, as well as provides an estimated estimate of their probability of being symptomatic at the time of plasma collection and at follow-up. So here's a QR code and URL that I'll provide at the end of the talk where you can access the web app. And I just wanted to note that this is a research web app and not meant for clinical decision-making at this time. But if you go to the web app, you're able to choose from which cohort of data you'd like to use, so NIGHT-ADRC or ADNI. You're able to choose from one of 6 assays, so C2N's percent p-tau217 or p-tau217, Fuji-Rubio's p-tau217 over A-beta-42 or p-tau217, and Janssen's p-tau217 and all-path p-tau217. You're able to choose from one of the 2 clock modeling approaches, TIRA or SILA. And then you can input an individual's plasma levels for the assay that you chose, as well as their age at plasma collection, and then time from plasma collection to a later follow-up time. And then the app provides an estimated age of biomarker or plasma positivity, as well as the time from positivity until plasma collection and follow-up. There's also 2 plot visualizations, so we provide the plasma clock for the assay you chose, and we locate an individual or the individual's input values on the clock at plasma collection and follow-up. And then finally, there's a survival curve that we provide, and it locates where someone would be on that survival curve based on their plasma levels at collection and follow-up, and a table at the bottom that provides an estimated age of AD symptom onset and their probability of having symptomatic AD at collection and follow-up. So just on a personal note, I had a family member who was diagnosed with AD within the last couple months, and I put her values in there, and I found it pretty spot on. Just anecdotal. But. So in conclusion, what we find is that plasma percent p-tau217 clocks enable prediction of symptom onset with high accuracy in a similar way to what we see using familial age of onset in AD-AD. And importantly, we see that younger people, or people that were younger at the age of plasma positivity, had longer times to develop symptoms versus those who were older when they became plasma positive. And then lastly, this work has the potential for improving clinical trials, hopefully by allowing us to identify people who are at risk to develop a cognitive decline within the period of a clinical trial. So I'd just like to acknowledge the FNH Biomarkers Consortium and ADNI for coordinating this project, as well as the many project partners who were involved. And there were many individuals from both academia and industry who collaborated on this project. So here is a QR code to the preprint of the manuscript that's related to this talk, and a QR code to the web app, which I encourage you to go to and kind of play around and try for yourself. Thanks.
Thank you very much, Dr. Kellen. And I just want to remind people that we'll be taking questions at the end, but please feel free to submit your questions via the online conference platform and the in-person app, because we're really hoping to have discussion for all our presenters. So our next presentation is going to be by Lundin Kohli from the Lund University in Sweden. And she'll be sharing trajectories of CSF and plasma MTBR tau, 243 and phosphorylated tau species across the Alzheimer's disease consortium. Welcome.
Great. All right, good afternoon, everyone. Although indeed the agenda still says Lund University, I'm officially now assistant professor at Amsterdam UMC, but I've done this work as part of my fellowship with the Biofinder Group under the supervision of Oscar Hansen, and I'm very glad to present to you this work. These are my disclosures. So we've seen from the donanemab trials previously, but also in general over the past few days, how important it is to get to the right patients, that we can inform on the potential risk-benefit ratio of these patients. As we know that the stage in the patients are in determine their possible clinical benefit, but also their risk of side effects. And even though PET might be the golden standard in this, we get spatial information and the extent, of course we can't do a PET image in everyone. So here fluid biomarkers, and particularly plasma biomarkers, can help us to individually stage patients. We have a lot of different phosphorylated tau sites that we can actually now detect in fluid biomarkers that can give us has been shown to change at different moments of the disease continuum. And we already previously showed that we can use this information to do CSF staging. And if you were just in the previous session by my colleague, Dr. Salvador, we've now attempting doing this in plasma as well. Or we can take two-step approaches where, for example, with p-tau217, we can identify those that are most likely amyloid positive and at high risk of of high tau burden. And of course, the recent developments of MTBR tau, they are more related specifically to tau PET burden and in a more continuous way. So here you can see for CSF, so on the left a plot with the relation between MTBR tau and tau PET, and on the right with 217, and similar findings were shown for plasma, where MTBR tau is more related to tau burden in temporometer voice than 217 was. But the question remains then, how do plasma and CSF p-tau forms all combined and MTBR change across the disease continuum and really can help us to optimally stage each individual? So the aim of this work was to investigate the temporal trajectories of mass spec-based measures of MTBR tau and p-tau species, both in CSF and plasma, so also compare their performance against disease time in relation to amyloid PET and tau PET positivity. And this was a collaboration between the Swedish Biofinder study and WashU. So for this, we included participants from the Biofinder study across the continuum, so SCD, MCI, dementia. You can appreciate that the sample size for CSF was slightly smaller, with 446 individuals available, but the amount of different p-tau forms were more extensive. I will not spell them all out, you can see it there. For plasma, we had slightly more individuals, 784, but less forms available. At least the key forms were included. And what's important here as the WashU platform is that we have ratios of the p-tau. So this is where phosphorylated tau is corrected for the non-phosphorylated, which has been shown to be more a robust measure of actual phosphorylated pathology. As many of the other talks that you've already heard the past few days, and also from previous presenter, we also use the SELA algorithm to determine amyloid and tau disease time. So in this case, not age of onset, but disease time. So basically retrieving individuals' estimated time from disease or biomarker onset or chronology, or how long someone has been biomarker positive. So for A-beta PET, this requires longitudinal data. We had 1,400 individuals, and a majority of those had longitudinal data with a follow-up time of close to 3 years. And for tau PET, you can see even higher numbers because as per design and the Biofinder study, we don't have amyloid PET in our dementia individuals. SELA requires a time zero definition, so what you basically anchor the scale on what is your tipping point of becoming abnormal. So for amyloid, we use the 20 centloid, and for tau, we use the 1.36 SUVR based on temporometeroid, which has been a previously validated cut point within this data set. So here on the left, you can see the raw data that we have in Biofinder. On the top is for the centloid, and the bottom is for temporometeroid, and on the right, how it's modeled for using the SELA algorithm. And in the interest of time, and considering they have the data available for all the individuals, we focus here on the tau curve and the tau analysis. But here and there, I'll make some comments for amyloid if it's relevant. For statistical analysis, so of course, as normal, we need to standardize our plasma biomarkers and we have log transform them. What's important is that we, for visualization purposes, and also later to determine the crossing point, so when someone or a biomarker becomes abnormal, we Z-score the biomarkers based on the variation of our cognitively unimpaired A-beta negative group. And for A-beta 40 and for MPOC, we inverted it, so all the curves going up means more abnormal. Then we determined the crossing time, so basically compared to this reference population, we wanted to investigate at what point a biomarker crosses the Z-score of 1.96 using lowest models, so we bootstrapped 1,000 times. We were also interested in some dynamic analysis, so just to look into basically how the different species behave, not only the ratio, but also the phosphorylated and not phosphorylated tau forms. We also wanted to see if we can maybe further improve the performance of MTBR if we do correct for a reference epitope, so like similar as to the ratio measures for p-tau. As previous work has shown that if you take some variability of inter-individuality into account, maybe the relationship to the Bragg regions improves. And we wanted to see to what extent MTBR was related to different tau burden across the Bragg regions. And finally, to make a better comparison, because we had these two subgroups of CSF and plasma, and there was only a limited overlap between the cohorts, but we still wanted to be able to compare. We also implemented the centimarker approach, where we compared the core biomarkers that we think that were the most interesting ones. Here, 0 centimarker, similar as to the centloid concept, was anchored in the mean of our amyloid negative CEU individuals, while the 100 centimarker was the mean of our amyloid and tau positive dementia patients. For the demographics, nothing unexpected. You can see the numbers here. You can see where the A-beta positives are in general with more advanced disease stages, a higher age. We see a higher centloid and tau PET burden, and it is as expected between the cohorts. Yeah, okay, there we go. All right, so let's go to the main plot, and it's a bit one, so let me walk you through it. So on the x-axis, you see the estimated tau PET positivity years, where the 0 is that cut point of 1.36 SUVR in the temporometeroid. And on the y-axis, you can appreciate the abnormality score for the different biomarkers. And just to highlight a few, so in the yellow, you can appreciate a p-tau 217, which shows the earliest change, but it showed also a plateauing effect upon longer disease duration. For 205, this changed later in the disease scores and sort of slowly continued. MTBR in the red very obviously shows later change, but close to tau PET onset, and really stoops up quite upon higher disease burden. And interestingly, the non-phosphorylated tau mid-region as a potential late-stage biomarker really shows only abnormality late in the disease scores. This was a significant abnormality threshold. And if you put it in the forest plot, we did 1,000 times bootstrapping, you can appreciate this early p-tau217 change, which actually was the only biomarker to show robust change also before amyloid PET onset. The other p-tau forms otherwise show very similar behavior. The 205 and MTBR are very close to tau PET onset, and the MP-tau is a late-stage biomarker. For plasma, we see a very similar trajectory, where again, 217 is the first, MTBR and 205 are more closer to tau PET onset, and MP-tau is mid-reaches, and again, a late-stage biomarker. All right. So to understand the different species, we wanted to see, we have the ratio measure that would show this plateauing effect upon longer disease duration. But what you can appreciate is actually that the phosphorylated form of tau keeps increasing over time. So it's a ratio measure that sort of cancels this effect out. And it would be interesting to see if maybe a combination of these factors could have also information. This effect was less apparent, though, in plasma, where we can see a more continuous increase in abnormality in 217 compared to CSF, making it maybe actually very useful also biomarker upon higher or longer disease duration, as I say. Finally, we saw that MTBR tau, so here in the dark red, mainly follows more cortical tau PET burden. So in the lighter purple, that is BRCA1/2, so it's less of a correlation with that one, so it's more and more advanced tau PET burden, and actually correcting it for non-phosphorylated tau did not improve that relationship. Plasma is quite impressive. It really mirrors tau PET burden in the cortical regions. Again, correcting for MP-tau did not improve this correlation, but you can appreciate how it really follows the higher burden upon longer disease duration. And finally, to somehow at least come to a more direct comparison using the centimarker approach to the core markers, what we can see here, where the 0 was the normal, abnormal, but we had a few cases of very high maximum level of abnormality because we had advanced dementia cases as well. And what we can appreciate in general, plasma biomarkers, they become abnormal slightly later than CSF biomarkers, but they show less of a ceiling effect. So even though it might be closer to the cut point of tau PET positivity, they are able to distinguish better, maybe upon the higher tau pathological burden. So with that, I would like to conclude that both CSF and plasma biomarkers show highly similar trajectories across the AD PET positivity duration. Both show, particularly 217, shows significant abnormality just before amyloid PET positivity as the only one, and increases abnormality long across the disease duration, although there was a ceiling effect, but this was less apparent for plasma 217. 205 and MTBR tau are demonstrated most change after tau PET positivity onset, and particularly plasma 8 MTBR tau shows very similar trajectories to cortical tau PET burden and intermediate late stage regions, so really tracking tau beyond the medial temporal lobe. The other CSF and plasma species, I did not show the plot, but they basically look all the same in the sense that they have very similar trajectories and very early ceiling effects, which also results in less utility for them for staging purposes. Together, these findings contribute to our understanding of how the trajectories of all these tau biomarkers in CSF and plasma accumulate throughout disease progression, and it could be used to optimize their use in clinical practice and particularly for risk stratification in clinical trials. Yes, but it really can help us to come to individual staging to help with our clinical trial design. And with that, I would like to thank you very much for your attention. Of course, the support from the group, from my fellowship. I learned a lot, and thank you so much. I'm looking forward to some questions later.
Thank you very much. That was a very engaging talk, and I hope that this generates questions. So those of you who are new or just joining us virtually, please submit your questions through the Q&A through the conference platform online or through your in-person app. So next, we're very fortunate to have Eric Johnson from Emory University in the United States sharing his work on using proteomics to stage Alzheimer's disease. So welcome, Eric.
All right, great. So thank the organizers for the invitation to talk about using proteomics to stage Alzheimer's disease. these are my disclosures. So I'm going to start this talk talking about brain, and clearly we're not going to be using proteomics in brain to stage Alzheimer's disease in living people, but I think it's a useful way to start for the rest of the presentation. So we did a study a few years ago where we looked at the brain proteome in two different cohorts, ROS-MAP and Banner, and these were individuals who were classified as control, what we call asymptomatic AD, or people that have passed away with a large degree of Alzheimer's pathology in their brain but are cognitively intact, and then Alzheimer's dementia cases. And we measured over 8,600 proteins in over 500 cases, and we analyzed the data using an approach called protein co-expression, which is a way to reduce the dimensionality of the data down into these things called modules, or groups of proteins that are co-expressed across cases. And you can see on the right here, the details are not important, but there are many different pathways and ontologies that one can assess using such an approach. And we identified two interesting modules in this analysis. One that we termed the matrisome module, which is really a collection of extracellular matrix proteins that are associated with primarily with amyloid plaques in brain. And also this other module called the MAP kinase signaling and metabolism module, which was the one that was most strongly correlated to cognitive function. And if you look at these groups of protein and their expression across these diagnostic categories, you could see that, for instance, the matrisome module was up early in people that were asymptomatic and did not change that much with Alzheimer's dementia. But these other modules here, for instance, the MAP kinase metabolism was more related to cognitive decline, as well as modules such as the mitochondrial module. So this is starting in brain, but of course we want to try to get at these changes using markers in biofluids. So the way we thought about doing this is to really go deep into the CSF proteome and map these proteomic changes in CSF back to brain. So this was a discovery study that we did where we looked at 40 individuals and identified proteins that were increased or decreased in Alzheimer's disease. And then each of these proteins, we could then relate them back to the brain module that they might be associated with. So for instance, a 14-3-3 protein like YAWZ would be mapping to a synapse neuronal module. Other proteins like PEBP1 would be a sugar metabolism module in the brain, SPPP1 would be an inflammation protein, and so on. So then what we did was we identified some higher value proteins that we thought would be interesting to measure, and we went into autosomal dominant Alzheimer's disease to look at how these proteins may change in the DIAN cohort. And we looked at 285 mutation carriers and 184 non-carriers with a panel of 59 proteins to see how they would change. And the value of this type of analysis is that in autosomal dominant Alzheimer's disease, you basically know when people are going to develop the disease. And so you can use cross-sectional measurements to put longitudinal trajectories for each protein. And here's an example of that type of analysis. If you look at the top, this is the A-beta 42/40 ratio. These individuals make more 42 compared to 40 throughout life, so it starts higher at earlier ages, but then as plaques form, that ratio decreases compared to controls or non-carriers. This protein below called SMOC1, this is a protein in that M42 matrisome module I mentioned in brain, and we see that there was a very early increase in that protein. In fact, it was 29 years prior to symptom onset, whereas the ratio itself was changed compared to non-carriers are 18 years prior to onset. So a very, very early change when plaques are actually starting to form and that ratio is decreasing. And so we could put all of these different measures into a timeline then based on EYO. And this is, a lot to look at, but I'm going to cut it in half. I'm going to expand it here. So on the left is the top and the right is the bottom. And here's that protein I just mentioned, SMOC1, which is increasing in red here early in the course around the time that A-beta is changing. And that's actually before p-tau217 that we, in CSF, that we measure change here. So this is a very early change associated with amyloid deposition. And then you can see, based on the different proteins associated with different brain modules, there's a lot going on in between these different kind of benchmarks. So we have a lot of synaptic and metabolism changes and stress response changes. Then it evolves into white matter and axonal integrity changes, kind of signified by NFL, which is starting to change around 10 years before symptom onset. And then after that, we start to see a lot of immune changes that lead to changes in brain thickness and eventual cognitive symptoms. So this is kind of putting all that into a general model for autosomal dominant, where you have early changes in this plaque and matrixome proteins that then evolve into synaptic and glycolytic changes, eventually inflammatory changes, and cognitive changes. So we've recently then applied this to another genetic form of Alzheimer's disease in Down syndrome, trisomy 21. And this is a study that we collaborated with Juan Fortea and Laia Montoliu-Gaia in the Dabney cohort. And it was just published this month, so you can read more about it. But we looked at some of these same higher value proteins in Down syndrome and compared them to what we saw in autosomal dominant. So that's on the left, autosomal dominant left, Down syndrome on the right. And you can see that most of these proteins are changed in similar directions, but the temporal ordering is a bit different there. And because we had measured many more proteins in the Down syndrome spinal fluid, we were able to use that same approach with the co-expression to identify different pathways there with a slightly different analytic approach. And I'm highlighting here when that A beta 42/40 ratio changes in Down syndrome. And you can see that in Down syndrome, there's a lot going on even before that amyloid is changing in the brain. Some of these markers are related to chromosome 21 and APP, and that second line there. But then you see things like complement and extracellular matrix and immunoglobulins that are changing. And then after amyloid, an early change in Down syndrome compared to autosomal dominant is NfL. And after that, then we see p-tau change. So that might signify that there's a lot of axonal and white matter changes happening in Down syndrome even before we see changes in p-tau. And then eventually we start to see a lot of immune changes that are associated with cognitive decline. So slightly different cascade of events here in Down syndrome for some of these proteomic markers. Of course, some of the standard markers are changing in a very similar fashion as Juan has shown in his studies. But there is some variation in these proteomic markers. So what about late onset? Of course, this is really what we want to be able to do with proteomics and late onset. It is more challenging because we don't have a benchmark per se like we do in autosomal dominant and Down syndrome. But I'm going to just talk a little bit about some thoughts, how we might approach this. We did a study here in late onset Alzheimer's disease. We looked at 300 individuals, about half Alzheimer's, half controls, defined by their CSF tau A beta ratio. And did a deep dive with two different platforms, SomaScan and mass spec, to really generate a lot of protein measurements, over 5,000 protein assays, and then took that same approach where we combine the two platform data and do a co-expression analysis and identify many different pathways in late onset that are changing. For instance, autophagy, ubiquitination changes, glycolysis, endocytosis, and so forth. And so then what I want to show here is that we can define these modules in this type of approach representing these different pathways, but then we can take the pathways and module proteins and use those to actually cluster people. So kind of go in the reverse direction, right? And get a kind of a sense of how people may vary based on their proteomic features. And so this is a lot to look at, but I'm just tell you the main features here. This is where we ended up with 10 different groups of individuals based on their proteomic features, and those are on the left here. These are the modules for 34 modules that we're defining people by. So for instance, if you look at some of these, like I just mentioned, the autophagy module and synaptic modules, this group of individuals on the left have very high levels of those proteomic features, whereas some of the groups on the right have lower levels. And you can see changes in other modules that might be even inverse. So complement and immunoglobulins lower on the left in those clusters of individuals where they're higher on the right. But the main thing to point out here is that this tract, right, in the top, this is the turquoise and the kind of that dark purple tract. This is the diagnosis based on the ratio, A beta and tau ratio. So the people that are purple have amyloid plaques based on that ratio, and the people that are in turquoise are defined as control. You can see that it's mixed, right? It doesn't separate out cleanly there. The people on the left are largely defined as Alzheimer's disease there, but there is some variation, whereas people on some of the groups on the right are mostly control, but there is a mix of what we define as Alzheimer's disease based on the ratio there. And so what does this mean? Well, we can think it might be related to different stages of disease, right? This could be maybe one continuum where we're capturing different stages of evolution of late onset. But it could also be that we have some different subtypes of Alzheimer's disease. There may be people that are on actual different trajectories here, and they have different staging based on that trajectory. So that's a tricky thing to try to sort out with cross-sectional data here, and we need more longitudinal data to really get at that, and that's a work in progress. So to summarize, we can use proteomics in spinal fluid to identify the sequence of pathological changes in Alzheimer's in autosomal dominant Down syndrome. We need to do more work with longitudinal samples and load cohorts to define staging versus subtype with proteomics. But these markers may apply differently to different types of AD, and that's something we have to consider when we talk about clocks and using these markers to stage individuals. And then, of course, we'd love to be able to get into plasma, and that is certainly more of a challenging matrix for proteomics, but that's also a goal, work in progress, and we need to do more method development there. So to acknowledge a lot of people that worked on what I presented today, our team at Emory, especially Eric Dahmer, Shija Bian, and Kathleen Carter, who were instrumental in this work, our colleagues in Dabney, with Juan and Laya at University of Gothenburg, our colleagues at WashU in the Diane study, our funding sources, and then of course the patients and families who make this work possible. Thanks.
Thank you, Eric. I'm really glad you brought the proteomic dimension into the discussion for our session today. And so just to remind those who are new and those who've joined us virtually, please submit your questions for the Q&A session, which will be at the end of our talks. So those can be submitted through the online conference platform or your in-person app. Please add your name unless you'd prefer to remain anonymous. So I'm very happy to introduce Hamid Abouwardi from Yale University. He's going to be sharing work on whole brain functional connectivity, predicts regional tau PET, and future cognitive decline in preclinical Alzheimer's disease. Welcome, Hamid.
All right, well, it's a pleasure to be here. I'm excited to talk to you guys about my ongoing thesis work that I've been doing in the labs of Dr. Carolyn Fredericks and Dr. Todd Constable. So yeah, I'll just jump right into it. I focus specifically on preclinical disease. I know everybody's aware of, but this period of disease presents with ongoing biomarker buildup over time without any overt cognitive symptoms. So there are many ways to kind of understand the heterogeneity of this disease. So we have amyloid and tau PET, CSF assays, and plasma assays. But for my PhD, what I'm trying to assess is, can functional MRI also play a role within this period of the disease? And so why do we think fMRI might be able to kind of shed light? We think it can really make inroads in a few different domains. So the first being identifying cognitive subtypes. So cognition is inherently network-based, and so it makes intuitive sense to use fMRI to study those networks that might help us, again, identify these subtypes. It may also help us identify differential progression. So we know that connectivity and pathology are very intrinsically linked. And so again, fMRI may be able to help us identify individuals who have a more aggressive form of the disease. And so what is functional connectivity? I'll just kind of briefly go over. So you take a brain, parcellate it using a functional atlas. You measure its activity over time, compute pairwise correlations between all regions within the brain, and that generates a functional connectivity matrix, excuse me, which represents, we refer to this as a functional connectome, represents all possible connections in the brain, and each cell in that matrix is a single connection. And so I first started posing this question: is there even a predictive relationship between the functional connectome and AD pathology and preclinical disease? And so I specifically use connectome-based predictive modeling. This was developed by my co-advisor, Dr. Todd Constable, and I apply it specifically in this cohort. So I'm looking at the A4 study preclinical cohort. These are amyloid-positive individuals as assessed by amyloid PET imaging. We take functional connectivity matrices from a 6-minute resting state image and also amyloid and tau PET metrics, and then input that into the CPM, connectome-based predictive modeling. And so I'll first start off with the amyloid models. We developed 3 models, one for a global composite, an amyloid global composite, commonly used in clinical trials and studies to assess for amyloid positivity, and also modeled amyloid in the precuneus and posterior cingulate regions. Reason being, we also developed tau models in these regions and wanted a one-to-one comparison. And so looking at these 3 models, we found that they were moderately predictive. So kind of across the board, there wasn't any real benefit looking at, the posterior cingulate, the precuneus specifically. And another thing I want to highlight is this really did require a very large sample size. So smaller sample sizes, you really did not get any prediction. Turning our attention to the tau models, we looked at all possible regions within the brain and found evidence of 14 total regions that demonstrated elevated tau in this cohort. We also developed a model for a temporal meta-ROI. This is, again, commonly used in the literature. It's outlined in red and helps kind of expand that dynamic range of observable tau. And so a few observations. First, looking at the posterior cingulate precuneus and comparing the tau and amyloid models, we did find that the tau models outperformed the amyloid models, even with a fraction of the sample. So you can see that it was much less power than the amyloid models. And this is kind of in line with a lot of what we know about tau and amyloid in the disease process. Tau is just really kind of intrinsically more correlated with a lot of the disease outcomes, and we extend that to this predictive modeling approach. Looking at all of our tau models, we found 6 total regions that were significant against permutation testing. So that was a posterior cingulate, precuneus, lateral occipital, middle temporal, and inferior temporal, and the bank STS regions. We did notably find that these regions outperform the temporal meta-ROI. So, there is likely some important information that you get at the singular regional level that you wouldn't get kind of just combining regions into a single meta-ROI. And then another observation is these regions that actually that were most accurate are regions that we don't expect tau buildup until much later in the disease, which is it felt a little counterintuitive. We have a few thoughts, and I'd be happy to kind of answer questions about that. So we then wanted to generalize these models, and so we took 211 amyloid-positive patients in the ADNI3 dataset and separated them into tau-elevated and tau-negative groups using a Gaussian mixture modeling approach. And we found that these models generalized to the tau-elevated but not the tau-negative groups, not only emphasizing the generalizability, but also the specificity of the models themselves. And so trying to kind of unpack the specific connections that were found to be predictive, we looked at the posterior cingulate, separated the connections based on whether they were positively and negatively correlated with posterior cingulate tau, and we found that there was actually a spatial distinction between the connections. So those that were positively correlated tended to aggregate in regions of the temporal lobe and the cerebellum, and those edges that were negatively correlated tend to aggregate in regions of higher association cortices, such as the parietal lobe. And so great, we can kind of predict pathology based off of functional connectivity. What I was interested in asking is, can we use these predictive models and features to really help define any clinical subgroups within this stage of the disease? And so I use a clustering approach that was developed and published last year. The citation is down below, and adapt it for our purposes. So I specifically look at the precuneus and lateral occipital models. The reason being, these are the models that generated the most stable clusters and the most separatable clusters. I separate edges based off of whether they're positively and negatively correlated. And for each individual, I calculate an average connectivity score based off these feature sets. I model these functional connectivity scores as a function of age, sex, motion, and scanner in an amyloid beta negative group. This is the learn arm of the study. And then apply the amyloid beta positive individuals to this model to assess how much do they deviate from this healthy control population. I use these z-scores as, so each individual is gonna have a set of z-scores, and use those z-score sets to essentially try to identify the similarity of individuals and their connectivity profiles within the amyloid beta positive cohort. And then use that, using that distance matrix, input that into the hierarchical clustering algorithm. And for us, it generated 2 optimal clusters. And so from here, we wanted to validate these clusters. Can we identify any baseline variables, or can we look at cognitive trajectories over time and see if there are any differences? And so looking at these baseline, various baseline variables, we actually didn't really find any differences. The only exception being race. So we did find a statistically significant difference that seemed to be driven by Asian identifying individuals in the second cluster. So we do include race in all of our models. It didn't really make a difference. But yeah, in terms of age, sex, education, ApoE genotype, amyloid burden, and these various plasma biomarkers, there was really no difference between these clusters. And so from here, wanted to then assess cognitive trajectories. And so we take an approach very similar to the A4 trial with a few changes and distinctions. Those are highlighted in red. And again, happy to talk about why those changes were made later on. And so looking at the primary endpoint of the study, we did find that there were differences over time between the 2 clusters. So the second cluster seemed to have a worse outcome over the course of the study. And this was reflected by the secondary cognitive outcomes as well. So on the left is a CDR sum of boxes. A higher score represents a worse outcome. In the middle, activities of daily living, a lower score represents worse outcome, and then cognitive function index on the right, higher score represents worse outcomes. So we're really excited by these results. Again, I want to emphasize that other than race, there really are no baseline differences between these individuals. So we may be capturing kind of an additional dimension that may have not been previously appreciated, and that may only be assessed and identified using functional MRI. So a few future directions, we're hoping that data sets will, not only include fMRI, but include longer scans and task-based paradigms. These have been shown to improve the estimates of connectivity. We also want to mechanistically define these groups, so we don't really have a strong prior belief as to what these groups represent. Are they lying on, different temporal timelines of the same subtype? Are they different subtypes? So we hope to kind of uncover that in the future. And then we also want to assess group differences according to treatments. And so in coming back to this question, can functional MRI play a role? I hope that I've convinced you that we fundamentally do think that it is going to be an important modality to use in the future. Thank you.
Thank you very much, Hamid, for sharing with us different approaches that are kind of looking across a connectome and another way of thinking of the brain and pathologies. So we're going to have our last speaker and then be opening up for questions. So those of you, you should all know the drill by now, that want to participate in the question and answer, please use the online conference platform or the in-person app. We'll also, if you're in the room, we do have microphones as well. So it's my great pleasure to introduce Lars Raket, who's with Lilly and is also the chair of the Design and Data Analytics PIA, and he's going to be sharing with us untangling the multiple timescales of Alzheimer's disease.
Thanks, Heather. So my disclosures, I'm an employee of Eli Lilly, but this presentation does not represent anything related to Lilly. It's entirely my own opinions I express. So I just want to revisit the amyloid PET clock here as the first thing to begin talking about multiple timescales in Alzheimer's disease. And I'm going to look at this classical construction. It's based on longitudinal amyloid PET observations, where we have here from ADNI up to 15 years follow-up. And the first step of this is that we center all of these patient-level samples. So 0 is the midpoint between the first scan and the last scan within an individual. And with this data, we then fit a linear mixed effects model with a random slope and intercept within each participant. So that model will effectively predict a line for each individual of how they're progressing on amyloid PET. So with this model, we can predict the centroid level at 0, and the model will also predict the slope at that centroid level. So if we plot that data against each other, we have this relationship of how centroids change in relation to which centroid you have. And this is essentially a differential equation. We have the change related to the value. So we can solve that by fitting a smooth function, in this case a spline function, and following the reference I have here, we only look in the central 90% of the observations to avoid effects of outliers. And then we can essentially just integrate this function. If we start at minus 20 centroids, we know exactly, the model will estimate how much the amyloid will increase if we take a tiny step, and then we can basically go down and say, if we have this new amyloid value, how much will the amyloid increase if we take a tiny time step? And when we do that, we generate this function that relates time since amyloid PET positivity, here defined as 20 centroids, to the actual centroid level. And this is the basic tool in the conventional amyloid PET clock. If you have a centroid level, you just project it onto this line horizontally, and then you go down and read. So if you have 80 centroids, it will correspond roughly to 20 years post-amyloid PET positivity. The same thing can be done with other biomarkers. There is this tau PET clock as well. And the question here is then, are these different clocks aligned? Because in the other talks we've seen today, we tend to stage things against a single timeline. And that's also how we think of autosomal dominant Alzheimer's disease. If we look at the Jack curves, there is this quite systematic cascade in Alzheimer's disease. But are things really synchronized? If they are synchronized, the tau PET clock and the amyloid PET clock should agree. So if we look within participants that have both amyloid and tau PET scans here in ADNI, then this is the picture we see. So there is clearly a relation. There is a Spearman correlation of 0.5, but there is also tremendous variation. So there is, if you look at deviation from the line, if you imagine that, we see the vertical deviation is easily plus minus 10 years, and the horizontal is easily plus minus 20 years. So that suggests that these two different clocks. They really don't agree very well on the staging of Alzheimer's disease on the patient level. So the question is, of course, what is driving this? I could think of at least three different explanations. One is that there are multiple timescales in Alzheimer's disease, that these two processes, the amyloid and the tau PET, or the amyloid and the tau accumulation, that they're not fully synchronized. Another explanation may be that the biomarkers are not really one-to-one representing what is going on in the brain. So there may be, it may be that there are uncertainties and that will somehow lead to these results. And the final one is that these amyloid and tau PET clocks, they have a methodological problem. So if we start with the last one, I will talk about an alternative here. So I'm a statistician, I have strong views on models, and I tend to prefer models where we directly relate the outcome we observe to the quantity that we're interested in observing. And the conventional PET clocks, they don't do that. They're multi-step approaches where you make assumptions at every step. Then you get a result that is associated with uncertainty, and then you do something to that. So it's a little bit hard to control how the uncertainty is propagated and if you have biases and so forth. So the general structure of these latent time disease progression clocks I will consider here is like this. We have an outcome of interest for participant I at visit J. That could be centiloids, amyloid PET. And we assume that that relates to a mean trajectory over the course of the disease, that there is some sort of natural history trajectory that is a smooth function over the course of disease. But we don't know if the observations from the participant we have, where they exactly relate. So we don't only use the time since baseline to evaluate where we are on the disease line. We also have this patient or participant level disease stage or clock that will offset where we're looking. So it will ensure that we have a time shift, so we're comparing the observations to the adequate part of the Alzheimer's continuum. And then in the end, we have a noise term. So this model, of course, also requires assumptions, and you could make many different assumptions. In this, I assume that theta is a 5-parameter logistic function, so that the things I'm looking at, they have a sigmoid shape, and I model SI as a Gaussian random effect, and then noise as Gaussian as well. So let me just show you what this results in when we look at the amyloid PET. So this is a single-step thing. We estimate everything with maximum likelihood estimation. So we zoom out and look at a greater timescale, and then the model will essentially align the individual patient samples along this greater timescale to find the best fitting sigmoid curve here. So that is all very good, of course, and we have also this timescale that's anchored in predicted time since amyloid PET positivity. If you look a bit at this, though, I think I would question the timescale, because we're estimating almost an 80-year timescale here, and I don't believe that amyloid accumulates over an 80-year timescale. I think even what we're seeing here, a 10-year timescale, we see very little accumulation in the first 10 years after patients become amyloid positive, and we know that that is not true from all of the data we have seen. There is a pretty rapid increase in amyloid. So that suggests that maybe there is a problem with using amyloid PET for staging patients this way. And the problem could, for example, be that the high centiloid values, they don't really represent a meaningful signal. It doesn't matter if you have 100 centiloids or 200 centiloids. That just means that you have a lot of amyloid in your brain. And it may be the same with lower values, that whether you have -20 or 10 centiloids, it's really just an indication that you don't have a lot of amyloid. So even though there is a problem, we can ask which clock is best, this latent time or the conventional. And I show here correlations to validation variables. Most of these are, so only the amyloid PET has been used to fit the model. And we see relatively good correlations across these different validation variables across amyloid, tau, and neurodegeneration, and some clinical scales. But what is interesting is that there's really no difference between the two approaches. And the latent amyloid clock clearly has some issues. So probably the conventional has the similar issues. And the same goes if we look at latent tau PET clocks. So the question is, could we do something else? And do we even need to do a PET scan to stage patients like this? I think Kellen's work was very encouraging with the plasma p-tau biomarkers. But I looked at another thing here, which is using just cognitive scores, CDR sum of boxes. How does that work? So the clinical measures here, we see pretty good correlations, lower correlations in general for amyloid and tau PET biomarkers if we only use the clinical scores, but better correlations, markedly better for hippocampal volume and for the clinical scales. And we know that the clinical measures, they're not sensitive in early disease. By definition, if you're preclinical, you can't use the clinical scores to stage patients. And maybe it's the same for the amyloid PET clock and the tau PET clock, that they're really only sensitive in a certain stage of disease. So maybe we could take all of these different biomarkers and combine them into a single clock. So this is very easy with this statistical modeling approach. You just make a multivariate outcome, and then you have a single timescale, and you try to predict. And when you do that, the model will stage every patient with amyloid PET, tau PET, and CDR sum of boxes data along the same timeline. And what you see here is that we have, first of all, a much more believable timeline, 20 years from amyloid positivity to end-stage dementia. But we also see that the variation in the amyloid PET signal in the end is huge. And the only reason the model allows that is that there is a very strong signal to noise in the CDR sum of boxes that is aligning patients much better in this later stage of disease. So how does this perform? I'll just quickly go over this and say, if you compare the numbers, you will see that this amyloid tau cognition clock, that performs as well as each individual clock. So it basically performs at the level of the best clock at each validation variable, suggesting that we have a staging along a one-dimensional time axis here, where we can describe a lot of variation. The correlations are very high here compared to what we're used to seeing in Alzheimer's disease. But I didn't really answer this question of whether there are multiple timescales in Alzheimer's disease. We can explain a lot of variation along a single timescale, but are there multiple timescales? And to do that, we can do a conditional correlation analysis. So what we do here is that we look at the correlations of one clock, for example, the latent amyloid PET clock, when we control for the latent ATC clock. And then we see how much additional information is explained by the clock. And in general, you can see here that the latent ATC clock has higher partial correlation, suggesting that there is additional information in that clock. But the latent tau PET clock, it doesn't have very high partial correlations, which suggest that the latent ATC clock captures most of it. I think most interestingly, there are actually some reasonably high partial correlations for the latent amyloid PET clock, suggesting that there may be an effect of amyloid accumulation that is not captured in this single timeline model that may explain some of the variability we see in Alzheimer's data. So just to conclude, I hope I've convinced you that these latent time disease progression clocks, that they are a reasonable way of doing this. They're data-driven and generalizable. Also that amyloid and tau PET quantifications, they don't seem sufficient to stage patients across the whole Alzheimer's continuum. They may work in certain subsets in preclinical disease or in early MCI, but if you have a very heterogeneous population, they will have some problems staging the patients accurately. And we can solve that by making clocks that are based on multiple measures. And then finally, that there do appear to be some biological timescales, multiple biological timescales that explain some of the variation that we see in Alzheimer's data. Thank you. Okay. So that brings us to our questions. And while you get to the microphones here in the room, I can see we've gotten a lot of questions online. The first one here is for Kellen, but I think it would also be interesting to hear the rest of the panel's thoughts on this. So the question is, do you think that you could improve these clock models by including additional biomarkers?
I've done a lot of thinking on this, and that's basically what I'm planning on doing. I think they can improve. I've done a little bit of preliminary analysis, and it improves things. You and I are much on the same wavelength about including, like, looking at different timescales as well. So.
I think the addition of additional biomarkers will always give more information and maybe can help us a lot with subpopulations. But there's always a trade-off, of course, between practicality and to what extent we want to bring it to a research or to a clinical setting. So I think that's why we need to find the balance, basically.
Yeah. So another question, we've gotten multiple questions about this, is about atypical clinical presentations of Alzheimer's disease. To which extent have you looked into these patients that have Alzheimer's disease with an atypical clinical presentation? And can the biomarker clocks, can they capture onset of these patients, for example, or progression?
Sure, yeah. So we haven't looked at the atypical population yet, but we are planning to do that. I think it's an important question because, you know, in these early onset patients, they tend to progress more quickly than later onset patients. And with the clocks that are currently proposed right now, that doesn't seem to be accounted for, right? It's not taking them 10 to 20 years to progress to symptoms once they're amyloid positive. We're progressing much more rapidly than that because they're age 50 already, right? So I think there needs to be more work done there. I agree.
I did it to a certain extent, actually. So I've been working a lot with Jake Vogel and the tau PET subtypes, trying to characterize them. And we applied the CSF staging that I briefly showed from Dr. Salvador to these different subtypes. So we have 4 subtypes. And actually, at least for the p-tau and biomarkers and MTBR, the trajectories are extremely similar. I could almost overlay them identically. So the underlying physiology in that sense is very similar, just the pattern is very different. And it's actually very interesting to, of course, think of what makes then the disconnect that we have the biomarkers in similar trajectories, similar extent of abnormality, but then still having a different pattern.
Yeah, that's extremely interesting.
No.
So we have a question at microphone number 5.
Hi, my name is James Dokie from Able in Australia. So my question was for the last presenter, Lars. Very nice work. Wondering, in your multivariate curve assessment, did you actually align the curves, or are each of the separate curves adjusted for one another, as each will have different variants and will provide different weightings to a multivariate model?
So so I aligned a multivariate curve, right, a 3-dimensional curve, and I assumed different variants in each outcome measure. So that is what is driving the fact that the CDR sum of boxes can dominate in the later stages, because the variance relative to the changes we're seeing is so low. So the model is quite certain that on how to stage in the dementia.
So is each of the separate curves in the multivariate adjusted for the other? As in, you know, the population curves are going to be different for each one. So, you know, is for example, the PET amyloid moved or shifted given the addition of the CSF, or is that not done?
I'm not sure I fully capture.
So in a true multivariate space, one marker will be adjusted for the presence of the other markers. So
Yes.
when you're looking at, if you're just aligning them, you don't adjust. But if you're in the multivariate space, are you adjusting then? So does the mean population curve, the sigmoid shape, is that moved left or right?
Yes, it does.
Okay.
So they will all affect each other, and I think that's what we see with the much increased variance and the much shorter time scale of amyloid PET.
Great, thank you.
Yeah, thanks. So microphone number 4.
Hi, my name is Taylor Bertucci from the Neural Stem Cell Institute. This question is for Eric. I really appreciated one of your last slides where you show that your load proteomics samples are clustering, not necessarily related to pathology. Did you look at other variables, ApoE genotype, sex, age, to help explain those binnings?
Yeah, so that was a really complicated slide. And those tracks above the pointer were ApoE, sex, and some of those variables. So some of those groups are, very enriched in ApoE4, for instance, and that might be explaining some of those modules that we see are actually very related to ApoE4 as well. So things like netylation and mitochondrial function as well. So, we didn't see a really big breakout by sex. And some of the other demographic variables. So or race, we didn't see a lot of that either. But a little bit with ApoE4, but we can look more into that.
How about vascular complications or CAA?
Right, so we didn't have those traits in that analysis, but yeah, that's one that we think some of those modules are driven by kind of blood-brain barrier changes or vascular changes. And like when I showed that Down syndrome kind of waterfall plot, our thought there is that some of those changes before amyloid that you see in Down syndrome are probably related to blood-brain barrier problems and leakage of some of those blood proteins into places where they shouldn't be. So yeah, I think that's likely a contributor to some of the heterogeneity there.
Thank you.
So we have a question online here for you, Eric, which is around biomarkers or proteomic clusters that are related to cognition. Do you find anything that is closely related to cognition and maybe within a certain disease, Alzheimer's disease, but also across diseases?
We haven't looked across diseases yet. We haven't done that analysis. What I showed there was really a cross-sectional relationship, and what we want to do is look at longitudinal outcomes in data sets like ADNI. So, do some of those groups if we can define those groups in cohorts where we have longitudinal data. Do some of them have faster progression than others, and that's work that we're doing, But yeah, I think we have to do more work with relating those clusters to cognitive function. The cross-sectional analysis I showed, that was a purely biomarker-defined definition of Alzheimer's disease. Those two groups, and some of those folks are preclinical, and there was a mix there. Some of those folks were demented, so we didn't see a huge cluster there by that.
Thanks. So a question for Hamid here. Was it possible to look into LC activity? If so, how predictive was it in predicting tau pathology and cognitive status?
Sorry, can you repeat the question one more time?
The question is, was it possible to look into LC activity in your functional MRI analysis?
Yeah, so we did not look at activity of the locus coeruleus. Our approach was a connectome approach, but the parcellation that we used did not have any subcortical parcellations that may encapsulate that. So, that may be kind of, a future direction to include. And there are newer functional parcellations that do a better job of identifying these nuclei subcortically. So, yeah.
Thanks. So, microphone number 2.
Quick question for Kellen. So the biological clock, I think, is going to be very useful. I'm curious what the future holds for it. If there's ideas that you can modify some of these changes with lifestyle or different drugs that come out or different things or maybe other demographic factors that you find out. I'm curious if there's going to be any sort of increased information additional to what sort of is there now.
I haven't thought about that very much. Something to think about. I've only thought about it in terms of multiplexing multiple biomarkers to create a timeline, but I haven't thought about external influences. That's something to think about, I guess.
Thanks.
So microphone number 6.
I have a question for Lars. I have two interlinked questions which are linked together, so I'll ask them together. So when you use this spline method to fit your data, splines are non-parametric, so they can fit to any type of data. And later on, you mentioned that your assumption is on a sigmoid function, which is a parametric method. So how do you ensure that you're not overfitting to the data using the spline method? Yeah, so basically what type of spline, are you enforcing like some monotonic behavior to become like a sigmoid so you can interpret the reflection point? And if not, how does this ensure that you're not overfitting to the data?
Yeah, so for the conventional or the classical amyloid PET clock, it just uses an unconstrained spline function, and I think I can't remember the exact details, but I think it's just a B spline with a certain number of bases that you estimate. You can of course put in constraints like monotonicity, and you can also make it. You can use a smoothing spline that will ensure that you don't overfit. But for this data, I think the thing is that you have so much data that it tends to not overfit because it's relatively low dimensional. For the other models, the latent time disease progression clocks, I used a sigmoid shape, and there is of course an assumption in that the biomarker you are looking at will be forced onto this sigmoid shape, and if it's not there, it will of course cause some problems. But you could use a spline for that model as well. But it all relies on whether you have data enough. And the interesting thing is that while they seem more difficult, these multivariate clocks, they're actually much easier to fit because you have much more information to predict this single staging variable for each patient. So I think typically overfitting would not be a problem if you have a large cohort.
Thank you, very interesting work.
Okay, so a question here for Eric. I've read studies showing parenchymal amyloid deposition in Down syndrome patients in childhood. How does that fit with amyloid coming later in the timeline according to your biological clock?
Well, first, I would say I'm not an expert on Down syndrome pathology. So, I think there are, even in autosomal dominant, there are early changes in subcortical amyloid deposition that are kind of these non-fibrillar plaques, so these kind of diffuse plaques. And I'm not sure, to what degree the CSF A-beta 42/40 ratio is capturing some of those subcortical changes in these genetic forms of Alzheimer's disease. But I think they do reflect at least pretty well the neuritic plaque fibrillar forms. And we're seeing, at least in that analysis that we did in the Down syndrome study, A-beta changes around 15 years before symptom onset, and we're defining symptom onset there as age 50. So we're not seeing those ratio changes as early as childhood there.
Okay.
And I don't have an explanation for that.
Yeah, another question here, maybe some background. So we know that the approved amyloid targeting therapies, they tend to give an immediate change in p-tau biomarkers. So there is a question about whether the panel would discuss how p-tau biomarkers could be used to monitor treatment, but maybe also how do biological clocks, how can we use them when we now have treatments that actually affect the biomarkers that we use to stage patients?
That was for me. Oh,
yeah?
Okay. No, so that's actually something I've been considering looking at, not necessarily, with applications towards monitoring treatment, but this idea of dynamic prediction or joint modeling with multiple biomarkers and how that would influence, time to event models. That's something I'm interested in. I haven't done anything on it yet, but it's interesting.
I think the challenge that we have, the tricky thing is here, is that if we see these changes in their p-tau markers, usually 217 across the trials, with the very apparent amyloid removal, and there's an overall effect. But if you actually look at the individual data points or the spread of the data in some of the box plots, the individual level is going to be extremely tricky. If you look, for example, the donanemab trial, those people that they showed in a supplemental plot that cleared 100 centiloid, their p-tau at follow-up is literally all over the place. So I think the issue for monitoring is that at an individual level, we really can't say anything. We see it at a group level at the moment. So the clocks can be used, at least at this extent, at this moment, for the disease staging before treatment and risk stratification, and mainly also probably reducing the number of confirmatory tests that we need in some cases. But we need to do a lot more work in understanding what actually happens to all our measures after drug treatment. So also now being approved in Europe, hopefully we can do that finally.
So why do you think it is that that we see these this heterogeneity on the patient level? Is it because these soluble p-tau species, they represent both amyloid and tau, so we have multiple sources, or?
Yeah, it's something we've been discussing in the group. That might be part of it, but also that might be just part of the disease mechanism, that removing the plaques or fibrillary plaques is not affecting the underlying disease progress that maybe is part of it, at least represented by the p-tau species. And that is of course not affected by the ATT. So I think that it's a probably multifaceted problem that it will be maybe tricky to tackle.
Yeah, I think it will be very interesting to see when we get the results in preclinical disease, if we will see much better tracking on the patient level with these blood-based biomarkers.
I just quick comment. I agree, and I think with preclinical disease where it's primarily amyloid, maybe we'll be able to run the clock backwards a little bit better than we are right now with with amyloid treatment in people that are symptomatic, because as you mentioned, some of that signal is likely related to tau. In later stages of disease, you just can never get it back to zero, right? But maybe in preclinical disease with p-tau 217, we'll be able to turn that clock backwards, or other markers that are really very specific for a certain endophenotype of Alzheimer's.
Yeah, so it would be very, very interesting to see the similar plots that we've now been seeing for MCI and mild dementia in the preclinicals, if the effect is the same. Do we see the same heterogeneity in that population, or is it more actually reflective of treatment efficacy? Let's see. Let's wait for the plots at CTAD.
Yeah. So microphone number 5.
Quick question for Eric. When you were showing the different protein modules, proteomics modules, you show many of them, if I understood correctly, appearing and disappearing, or having transient, let's say, representation over the course of trajectory. That is great for all of us that do trajectories, because those are not monotonic functions that you can build, one-on-one transformations to a common timescale. So I wanted to ask you a couple of questions. Like, one is, which one were there or were there any ones that were remarkable that you think, okay, there is an inflammatory period given by something, or like, what can you comment on that? And the second one is, can you use those transient modules, if I understood correctly that they were, to maybe create stagings, like detailed stagings? Okay, the progression of disease goes through these different stages given by the appearance and the disappearance of these proteomics profiles.
Yeah, so that's a great observation. Let me make one caveat about what I showed you there. We have to have enough measurements at certain time points to get a good confidence, right? So, for instance, in the Down syndrome, what I showed you there, we have very few points that are beyond 10 years EYO, right? EYO 10. For obvious reasons, it becomes very difficult to get those measurements. And so the confidence becomes low, and that's we can't say that there's a significant difference there, even though there would likely be if we had the data points, though. So it's not that all these measures are appearing and then disappearing later on in the disease. It's just that within those time periods, we don't have as much statistical confidence to say there's a difference. But in those areas where we have a lot of data, we can build confidence estimates of these trajectories. And I think, looking at where someone might be kind of in that waterfall cascade, where they have some of these protein changes compared to controls, but not others yet, kind of puts them on that clock or trajectory, if you will. So it's a good observation. There are some that do seem to be somewhat transient. So the glycolytic metabolism I showed in the Diane study that you have a peak and that kind of goes away, and then you have another peak around the time of symptoms. And we don't really understand that, what's going on there, but there do seem to be kind of two distinct periods there with glucose metabolism that's changing. So that's interesting.
Thank you.
Okay, so if there are no more questions, I think we should end the session. So thank you so much for attending, and have a good rest of the day. I assume many of you will go to the social event.